I hope I meet these trainees in orthopon. We should meet each other, and I will try to announce our exam review course in orthopon, and we will fix a date in a day or two, and then we can spread the word out. And
Okay.
it would be we try to do it in one day, and someday on Friday or Saturday, or it could be both Friday and Saturday, and we could cover most of the important topics.
So where is the review course going to be?
It's going to be in our hospital in Peshawar.
And when?
In Hyderabad.
When?
The date we will decide in a day or two.
Okay.
So we finalize the date.
So,
yeah.
Okay. So
but we try to keep it soon after orthopon.
Okay.
So,
if you start, everybody will inshallah join us. Yeah.
Yeah. So should we start?
Yes. Yes.
Okay. So so this is going to be a little bit informal talk about hip pathology in children. So I want to make it clear a few things that this is going to be strictly for exam purposes. So so all these things are for exam only. So for patient management, it's also important, but this is for the exam thing. And it will be how to approach a patient with hip pathology, a child with hip pathology. And the things written in the books, I try not to discuss those because the trainees here have a lot of knowledge. Once they've given the paper, they have a lot of knowledge about what's written in the book, and they can reproduce that pretty well. So detail of the diseases, I would not discuss in detail, but I would just like to mention them. And so how to approach a patient, a child with hip pathology. Uh, so a child does not, if you enter the exam, the child does not have something written on his forehead that I have a hip pathology. So how do you suspect a hip pathology, right? So obviously the history is very important, and you have clues in your history, and the history should be in a certain pattern. So you have, there is an aim of everything and a pattern for everything. So the aim of history is to reach the diagnosis or differential diagnosis, and there is a pattern of history. So if your aim is correct to reach a diagnosis and your pattern is correct, you would have no problem. If your pattern is correct and your aim is not correct, you're not going into a direction, you are going haphazardly, then there will also be a problem. So you have to be very clear about this. The history should be very straightforward. It should be directed to some pathology or one or two pathology. You should narrow it down and bring it up to one pathology, and there should be a definite pattern. Also, the examination should have an aim, and the aim examination is to confirm your diagnosis, which you have made while taking your history, and also to exclude other differential diagnoses, which are the probable diagnoses which you had. And there should be a pattern of examination as well. So if your aim of examination, your pattern of examination is correct, then you would have wouldn't have any problem. You can ask questions freely in the middle if you have anything. Okay, so so how do you suspect a hip pathology when you enter the examination room? A child sitting in front of you. So it starts right from the demography of the patient, the age of the patient. It's very important. So whenever you the age of the patient, there are certain diseases which are common at certain ages. Also, whenever you ask about the chief complaints, which could be pain, which could be a limp, which could be deformity, which could be weakness or something else, you get you tend to make a list of differential diagnosis after the chief complaints. For example, the child is having a limp. He's having a painless limp. So you have a list of differential diagnoses in your mind. It's a 9-year-old or 10-year-old child. He has a painless limb. So it could be, in our country, it could be, think of the common things first. It could be a neglected DDH. It could be a pathology or sequelae of pathology. It could be sequelae of septic arthritis. It could be coxa vara. It could be deficiency of any of the bone, especially type 1 PFFD. It could be snapping of the hip, painless snap. It could be, I mean, it could be something like a mild type of CP or a mild type of polio, or it could be just femoral versions, or it could be snapping or something like that. So these are the differential diagnoses which come up into your mind if it's a painless limb. So during your history, you should look for clues. So you should look for clues. Is it congenital? Is it acquired? Was there preceding pain? How did it progress, and how is it progressing now? How do you come up to it now? So these are the clues. So you have to get a detailed history, and with every point of your history would exclude a, a diagnosis. For example, if the limp was from right when the patient got started walking, so it could be DDH, or it could be coxa vara, or it could be femoral deficiency, a mild type. Or if the limp was not from that time and it started when she was 5 or 6 years, it could be sequelae of septic arthritis, it could be perthes. Or if a limp started after 10 years, it could be slip epiphysis, it could be labral pathology, intraarticular pathology, right? So these are the clues. Clues in past history, birth history, developmental and immunohistory. You should also look for clues over there. So important thing is the history not only for diagnosis, but also it is for management purposes. Like you should ask for other things like once you've made through 2 or 3 diagnoses at the end of your history, you should ask a few questions regarding the management and the complications, the potential complications of those diseases. For example, if you have made a diagnosis of Perthes disease, so so it could be then you examine and the hip range of movement is slightly distracted. So you should think of other differential diagnosis which causes decreased range of movement in the hip, and it could be multiple epiphyseal dysplasia, and you should examine the patient according to that. It could be sequelae of septic arthritis. The hip examination is almost the same, and you should examine for that. You should ask. You can again ask questions when you are examining the patient that was there any preceding pain, or was there fever, or was there a discharging sinus, and you look for clues in the history over there. You can always again ask questions when you are examining the patient, and you look for potential complications as well. And you ask about, you think about treatment options, and you ask about if the treatment gets prolonged, if there are multiple visits, if the cost is higher up. You should ask questions like these as well. So the examination aim is to, as discussed, to confirm the diagnosis, to exclude all, which means to exclude all the other differential diagnoses, and you have a set pattern. So things not to forget during examination of the patient, especially if there's a hip shoe examination, walking examination is very important. These are things which commonly the trainees forget, right? So we will discuss them one by one. And the gait is very important. It's not just simply the gait. It's the whole cycle of it. Like, it's not just to make it walk. Uh, there are some sounds.
Yeah, I've stopped them. It was a Fox telephone. Please, guys, if you're not
Okay.
asking, mute yourself, yeah?
Okay. Okay, so the gait is not that simple that you can just make the patient walk. You should look for a lot of things in the gait. I mean, the step pattern, the cadence, the version of the femur, which is indirectly seen by the in-toeing or out-toeing, the balancing, the spine you also see, the pelvic level you also see in the gait. And then after the gait, you make the patient squat and do tiptoes and cross legs, things like this, and you have some idea about how things are going on. Then you must not forget the Trendelenburg and hip examination. You may make the patient lie and do a Thomas. We will discuss. This is just the overview. These are things not to forget: limb lengths, and examine every hip I mean, if the patient is complaining of knee pain, you must examine the hip fully, right? But the pattern should be the patient is complaining of knee pain, you examine the knee first and then examine the hip. If you examine the hip, a patient is complaining of knee pain and you examine the hip right away, it does not look good. It's not a correct pattern. So you should exclude the knee pathology and then examine the hip fully, not just exclude or screen the hip. You examine the hip fully in case of any knee pain or knee symptoms, and examine the spine in case of the spine fully in case of any hip or lower limb pain. You have to exclude spinal pathology. Also, you have to look for intra-abdominal pathologies as well. So it can cause referred pain to the hip as well. For example, testicular problems in males or intra-abdominal pathologies, any pathology in male or female. So examination, you have to make a plan. This should be pre-planned. You have to take your time out and you make a plan for each and every system, for the hip, for the knee, for the ankle, for the spine, for the shoulder. For every region, you make a set plan. You have to do logical interpretation of findings. If you find a positive finding in your examination, you have to think logically and act according to that. For example, if you see shortening, in your examination, what is the next step? What do you do after that? If the patient is dying and there's around 2 to 3 centimeters of shortening, what is the next step? How would you react to it? Can I ask questions?
Yes, of course you can.
So if you see a 3 centimeter shortening in a 10-year-old child, what is the next step? How do you proceed after this?
Come on, guys.
Okay.
You said we're going to be active, so there's loads of.
Yeah, you can say anything.
See a shortening, then you should probably do a further examination, I think.
I'll do the Galeazzi test and check whether the shortening is in femur or tibia. Then I'll make.
Yes, excellent. Yeah. So this is how you logically interpret and you act according to the situation. So if you see shortening, you directly do a Galeazzi test, and they see whether it's in the tibia or in the femur. So if it's in the femur, you should directly go whether it's supratrochanteric or it's infratrochanteric. So you do the branch triangle, central lines, clean lines. So so this is how you logically interpret your finding. For example, you find out that that's in your examination there might be a coxa vera. So how do you react after that? What do you do after this? So the greater trochanter is proximal. There is supratrochanteric shortening, and there is increased adduction and decreased abduction and extension. And in flexion, it is almost normal. So, and the rotation is also normal as well. So you're thinking it might be coxa vera. So what else do you want to see in these patients? How do you react to this as well? Yeah. Okay, so coxa vera, you think of causes of coxa vera, right? So coxa vera is not a diagnosis. So you think of causes of coxa vera. So it could be a healed Perthes disease, in which the rest of the examination would be almost normal. It could be sequelae of septic arthritis, right? Then you again you can always go back to the history and ask according to that. It could be rickets. Rickets, it's very common in our country to have rickets, and coxa vera is very common. So you see other sequelae of rickets, right? So you examine the knee, you examine the wrist, you examine the chest for pigeon chest, you examine the skull and the eyes and ears and things like that, right? So this is how you react to a certain finding. So you should logically interpret. What if there is a decreased range of movements in the hip, all of the movements, and it's painless. It's a painless decreased range of movement. So what are the differential diagnoses that comes up into mind? So, yeah. So all the range of movements are decreased. So again, you're thinking of things like
I'll think of tuberculosis rather.
Yeah.
And
yeah. You think of 3 or 4 things. One thing, for example, you think of the common things first, not the rarest things, right? So you name the commonest things first. So common things are, in our country, Decreased range of movement, it could be sequelae of septic arthritis, again, Perthes disease, right? It could be multiple epiphyseal dysplasia. So you ask questions according to those. We will discuss all these examinations in detail, right? So supratrochanteric short. So what causes supratrochanteric shortening? This is important. So this is the most common sign which we see. There is a shortening, and if there is a hip pathology, there is supratrochanteric shortening. So again, common things first. So for example, it's a 9 or 10 or 11 years old child, and there's supratrochanteric shortening. So what comes up into mind? What things would you like to exclude? Yeah.
DDH.
Yes. Very good. Common things first. DDH.
Any pathological dislocation like tuberculosis, in which Mutard
Yes,
testility
can
has.
be dislocation due to any other causes, right? But that would cause a decreased range of movements in positions, yeah. There will be additional findings. More things, supratrochanteric shortening, very common sign which we are dealing day-to-day hip examinations.
Neck of femur non-union.
Very good. You always think of fractures and its complications in
Yes.
any disease, right? So non-unions or malunions. Non-unions are a little common in children, but malunions are quite common. Yeah. Yeah. Again, we have discussed things like Perthes disease can cause supratrochanteric shortening and Coxa-Vara. Slipped femoral epiphysis, especially the severe slips. And the stable slips, they can present an exam. The unstable, they would not come into the exam, but the stable slips would come into the exam. Malunions, Coxa-Vara, proximal femoral deficiency. But in this case, the shortening is quite a lot, but it depends on the type of the deficiency. So if it's a type 1 PFFD, then it could come up in the exam and it could present as a supratrochanteric shortening, or it could present with both supra and infratrochanteric shortening. And sequelae of septic arthritis, this you should consider in any pathology, right? It's very common in our country. So what if there is decreased internal rotation? So what does this indicate? What pathologies? What should you look into?
Slipped femoral epiphysis.
Yes, excellent. So in mild cases and in acute cases, there is decrease. The internal rotation is painful, but in moderate, severe, and stable cases, there is no internal rotation. In fact, if you flex the hip, it goes into external rotation. So there is minus 10 or 20 degrees of internal rotation, right? Very good. More, anything else? So we would like to discuss.
Again, sequelae of septic hip, maybe.
Very good. Sequelae of septic hip. You can always include that in anything, yeah. And Perthes. In Perthes, the first sign is decreased internal rotation, and it persists, right? So what if it's a painful internal rotation, and it is decreased? What comes into mind? So any intra-articular pathology, acute, it would cause decrease in internal rotation. If it's an intra-articular pathology, it would cause a decrease in internal rotation or a painful internal rotation. It could be transient synovitis initially in young children. It could be the start of septic arthritis. So initially the internal rotation is pain, but in septic arthritis later on when it's full blown, all the movements, even the mildest of movements, are painful. It could be start of a acute slip in which you cannot differentiate whether it's a slip or not. If the internal rotation is painful, the X-ray seems normal. There is there's always effusion inside the joints, so you should suspect different devices.
So
Intra-articular pathology, osteochondral fractures, hemarthrosis, all these things cause painful internal rotation, right?
all the
So
pathologies
what
which
about
cause
DDH?
capsular distension, we can label cause internal rotation deficit. Capsular distension. All the things which cause capsular distension.
Yes, any pathology which causes capsules. What about DDH? What would be the rotation in DDH like? A dislocated hip, congenital dislocated hip.
DDH depends upon the stage of the deformity. It won't be painful.
Okay, it would not be painful. Obviously, yes, it would be a painless condition. So what would be the rotation? Say, would it be increased, decreased, internal rotation, external rotation? So
I
in
believe it
DDH, the
decreases.
rotation is actually increased, right? So if there is supratrochanteric shortening, right, and the rotation is increased, especially the external rotation. So this could be DDH. You should exclude. You have DDH in the differential diagnosis, right? In Perthes disease, as discussed, it would be decreased. In conditions like post-polio paralysis or CP, it could be a lot of variations. So if you have I mean, I have seen a few patients in which the only hip is involved in polio, but I see a lot of patients. I see about 100 patients in ProPD. But these are quite rare. So if you don't have any other stigma of these diseases, it should be bottom of the line, right? So PFFD again, it
I
depends
have
on
a
the type.
question.
Yes.
Yeah, in cerebral palsy, we consider the spasticity and the increased tone of internal
Yes.
rotator. So there would be a decrease in external rotation.
So there is decrease in all the movements in CP basically, especially the extension because the psoas is tight, the
Yeah,
abductors are
because of
tight,
the
the
soft is
adductors are,
solid.
yeah, and the adductor is almost always tight. So there is decreased abduction and decreased rotation, right? So all the movements are decreased in the CP hip,
So the
right?
cerebral palsy and polio will have a contrasting picture to each other, isn't it?
Obviously, if the hip is involved in polio, the movements would the range of movements would increase, but there could be a flexion contracture, right? There could be a flexion contraction. The Thomas could be positive, but generally there is weakness of the abductors, weakness of other muscles. The flexion contraction is not due; it's due to something else, right? So generally,
Can I say
the range
something,
of
Salik?
movement
Yeah.
in post-polypedesis in the hip is increased, except for the extension, right?
Can
Understand?
I just say something?
Yes. Thanks.
Yes,
Hip
Mr.
has got a whole body attached to it. We're not just looking at the hip. So you must not just make a diagnosis at looking at the hip. Alex
Yeah.
is showing you what to look at when you're focusing on the hip. But don't forget, cerebral palsy, polio, development dysplasia, these are all different entities. There are a lot of other telltale signs. You cannot be asked or not be expected or should not be trying to diagnose the pathology by just looking at the hip lines.
Yeah.
Everything else is included.
Yeah, if you see spasticity and the hip, you should look for other signs of CP, right? You should examine the whole patient, and not just put the diagnosis. Yeah, it's very well said. Thank you, Mr. Noor. Yeah. And septic arthritis malunion always put into differential diagnosis when the rotation are decreased, right? So what if there is problem in adduction and abduction? So in DDH, there would be increased adduction and decreased abduction, right? Especially in extension. In Perthes disease, it could be variable, but generally the abduction is decreased. In Coxa-Vara, again, there could be, there is hinged abduction, so abduction is decreased, especially in extension. But if you flex the hip, then the abduction could be improved. Again, CP polio is discussed. PFFD depends on the type of PFFD, but if it's a mild type, it could be normal. Sequelae of septic arthritis malunion, they are generally decreased. So I hope you know a lot about in-toeing and out-toeing. So during your gait and during examination, if you find in-toeing, it could indicate a hip pathology. It could indicate a lot of other pathologies, but you should exclude the hip pathology in in-toeing as well. So what could be the hip pathology if the patient is walking in toeing? So the ankle, the knee, and the tibia, the femur, the rest of the femur is normal, and you are suspecting a hip pathology, and the patient is walking with in toeing. So what could be that pathology?
Increased femoral anteversion, sir.
Yes. So increased femoral anteversion, the patient compensates. So this is important you understand this. the patient compensates for the abductor lengths to improve the abductor's intoning of the thorax, or to bring the trochanters, because in increased anteversion, the trochanter has gone posteriorly. So when the patient intoes, it brings the normal position, and so that he walks better. And outtowing indicates obviously a
I'm sorry.
retroversion. Yeah.
Sorry, can you repeat this whole line? Line was interrupted actually.
Okay, so this is very important. I thought you would know this. I just went through it. So if there is increased femoral anteversion, so the angle between the neck of the femur and the posterior line of the femoral condyles, this is what we are talking about. This is the version of the neck. Do you understand this? The version. The version is the angle of the neck, right, in coronal plane with the angle of the posterior condyle of the femur, right? So if there is increased version anteriorly, so the head would be pointing anteriorly, more anteriorly, and the trochanter would be pointing most posteriorly. So you can see me, right? So this is a normal hip. These are the heads. So if the heads are pointing anteriorly and the trochanter goes posteriorly, so this is increased femoral anteversion, right? This is normal version. This is increased femoral anteversion, right? So if there is increased, the abductors are over lengthened, so they cannot act according to the hip. So the mission is that the patient in toes, right? So it internally rotates the whole of the lower limbs. So to improve the abductor tone, abductor length, the abductor length. So this called, so the patient can walk better, right? So this causes in case of increased anteversion. Understood?
Yes, sir.
Is it clear now? Okay, thank you very much. Okay, so outtowing is the opposite. So if it's a retroversion, the patient outtoes and brings back to the earth. So what other common condition can cause outtowing gait apart from retroversion? It's very common. So what other condition? It's a very, very common condition, and if the patient is walking with the outtowing and there is slight shortening, there's obviously always supratrochanteric shortening, and this is the scenario. And what is the differential diagnosis? The main diagnosis comes into mind. And when you examine the hip, in extension, the range of movement is almost normal, but there is decrease in internal rotation. But you should flex the hip. The hip goes into extension, and there is no internal rotation. And the patient walks without
avian.
So it's a slipped. This is a very common scenario for a slipped femoral epiphysis, right? A slipped epiphysis, femoral head. Is it clear? Okay, should we proceed? Okay, so outtowing could be increased retroversion, or it could be slipped femoral epiphysis, right? So you should make a plan for your examination. So the plan is consent exposure is very important. In standing, you start with the inspection from front, back, side, shoe examination, walking gait is very important, and then you do the gait. So we will discuss gait in detail in a few minutes. Then you do a Trendelenburg test, squatting, cross legs, tiptoes, heel walking, and screen for spine, upper limbs, see effects of the hip pathology on the knees and ankle, whole of the lower limb. In sitting, you examine again the spine, knee, full range of movements, you screen for the feet, and then you can examine the hip range of movement as well a little bit. But in spine, you should examine the hip in detail. The first thing which we do in spine is do the Thomas test. Excuse me? Yeah.
Nobody's asking a question.
Rest of the hip examination, whole of the examination, and the hip examination is done with the pelvis stabilized. This is very important. You should stabilize the pelvis. You should look at the pelvis. Once the pelvis starts moving the hip range of movements is over. So flexion up to 120 degrees is normal. After that, if the patient brings the thigh to the chest, this is not a 160-degree flexion of the hip. He just flexes the pelvis, right? In abduction, the patient could also 40 to 45 degrees of abduction. If the patient goes beyond that, it abducts or tilts the pelvis, right? So you
Can I
should,
ask a question?
yeah, sure.
So if there is a fixed abduction contracture of 20 degree,
Yeah.
then we won't be checking adduction anymore in Thomas.
If there is a fixed abduction contracture,
Yes, sir.
then
Then we won't be checking adduction anymore.
what you will check, but there would not be an adduction. Once you you would be able to bring the limb into adduction, but the pelvis would tilt. I will come up to this adduction abduction thing at the end of the examination. I will discuss
Okay,
it in
okay.
detail. Okay, so just wait a little. So after this, the range of movements, you pick up your measuring tape, your marker, and you put marks on the patient. Right? You get a consent from the patient to put marks, and you measure the limb lengths, wasting, the Q angle, bank angle, if there is a pathology. So this is how you do it. This is how I would do it. This is the patient exposed, and these are my marks at the umbilicus, medial malleolus, the anterior spherical spine, the medial joint line of the knee, the greater trochanter, the lateral malleolus, the mid of the patella, the tibial tuberosity, the lateral joint line of the patella, the 15 centimeter proximal to the knee joint, and 15 centimeter distant to the knee joint. So these were my 11 or 12 marks which I would do, and these marks, if you do put all these marks on the patient, it's a lot of marks. You have to obtain a consent from it. You would not miss anything, right? So by these marks, you can do the true lengths of the apparent lengths, the true lengths, lengths from the trochanter to the lateral malleolus, lengths from the anterior superior spine to the medial malleolus, and differential lengths of the femur and the tibia. And you could calculate the Q angle, and the pars proxy on the thigh and on the leg. You could measure the wastings. So these are all the marks you need to put on the patients in case of lower limb pathology, hip, knee, or ankle pathology, whatever, or even spine. Okay, so these marks are in case of spine, you have to do the 2 marks on the spine for flexion and extension as well, in addition to that. So distal examination of neurovascular is very important. And you, on the side, then after that, you put the patient to the side and you do the obers and the hip extension on the side, you recheck it. You can also do the abductors, measure out the abductor strength in overs, in lateral as well, muscle power. So I would do the GPE and systemic examination at the end, but you can do it in the start as you wish, as you feel comfortable. And again, the findings should be logically interpreted, right? So your examination findings should point towards towards the diagnosis, right? Should explain the deformities. So I hope you know all about the Trendelenburg gait or sign or test. So, but for those of you who don't know, when the patient is standing on a limb, we check the abductors of that particular limb, right? It's not the opposite limb, right? So if the patient is standing, this is from behind, the patient is standing on the right limb, so we are checking the abductors of the right limb, right? So this is a normal patient. The patient is standing on one limb, and the pelvis is perpendicular or parallel to the ground, or perpendicular to the long axis of the femur. If there is any problem, weakness, or lengthening or shortening or damage to the abductors, which could be anything, we will discuss those. So the abductors will not be able to maintain the pelvic balance. So when the patient stands on the right lower limb, so the pelvis would drop to the opposite side. And in order to keep the pelvis straight, the patient may sway to the right side, right? So the swaying is again a sign of Trendelenburg sign. So what could be the pathologies if the Trendelenburg sign is positive in a patient? So what things come up into mind? What should you exclude you during your examination? Trendelenburg sign is positive. Yeah.
So common things, guys. Come
So
on.
common
Sorry, sir,
things
can
are
you
common.
repeat the question?
Yeah. So the patient has a positive Trendelenburg sign. So what could be the differential diagnosis? What are the conditions leading to this sign?
Abductor weakness.
Yes, that. But I'm talking about the diagnosis.
Yeah. It could be because of the inflammatory condition. It could be because of
Like,
the paralysis of the muscles. It could
very
be
good.
post-traumatic.
So if I
It
do a
could be
Trendelenburg sign in a person, I am not looking for paralysis of muscles. You know, what am I
Yeah.
looking for to confirm my diagnosis?
More common things. Yeah.
common things so things which can do a supratrochanteric shortening,
Very good.
like a fracture of the femur, femoral neck, or an arthritic hip with erosion,
Okay.
neck of femur fractures. These
But
can lead to
it's a
decrease
10 or
in length
12
of
year
the
it's a 10 or 12 years old child, and he has a Trendelenburg sign positive.
DDH.
Yes. Supratrochanteric DDH, right? This is one thing, yeah.
Or it could be an post-infected avascular necrosis of the hip.
Right. So all the conditions which we discussed causing supratrochanteric shortening, right? We discussed supratrochanteric shortening, right? So we discussed Coxa vara, DDH. Perthes disease can cause Coxa vara and all kinds of deformities. A slipped femoral epiphysis can cause a varus deformity, right? A heel slip or a stable slip. Femoral deficiency, rickets, right? Rickets and Coxa vara, Perthes and Coxa vara. Rarely it could be a muscle weakness, but you should not consider muscle weakness into your exam, right? Muscle weakness is very rare and it's seldomly presented. I have seen one or two patients, but I don't think you should name them in exam. So any disease causing supratrochanteric shortening would cause a abductor, or it could be sometimes it is iatrogenic. I mean, there's a hip pathology and some person operates on it, and it, for example, if it's a DDH surgery and some surgeons lift the blade and they do not attach them back in its proper position. So in hips surgeries, the DDH surgery, incorrectly done sometimes, it could present as a Trendelenburg sign, right? Okay, I hope you know all about the Thomas test, right? So the top picture shows that the hip is in full extension, but there is hyperlordosis of the spine. So this is a pseudo extension of the hip. The patient is using the pelvis to extend the hip. Whenever the spine is, the lower picture, the spine is straightened out, there is a flexion contraction. And I hope you know how to do the Thomas test. I hope you know everything about the Thomas test, right? So what could be the cause if the Thomas test is positive? What could be the causes? Yeah, there is a positive Thomas test.
So you guys are doing
So what
exams that
things?
come so long ago. You should know this on your tips. You know, if somebody asks you.
Yeah, this is
So
very
all the
common.
eight pathologies probably.
Yeah. So again, you divide them into
Exam
bony
answers, all the
pathologies or soft
pathologies
tissue
that we've
pathologies.
just discussed. That it means nothing, right?
Yeah.
And just before I forget, how many times do we do a Trendelenburg test in an adult with a fractured neck or femur?
Yeah.
Yeah, so you answer things like that. The examiner who's asleep will wake up. And if he wakes up, you're in trouble then, isn't it? So make sure your answers are logical and they are correct.
Yeah. So mainly it's soft tissue pathologies which causes these positive Thomas tests, but it could be bony pathologies sometimes as well. So it could be a capsular contracture, it could be a psoas muscle contracture or spasticity, or it could be a bony deformity, malunion of the proximal femur, right? So these all could cause a positive Thomas tests. You can think of all the potential diagnoses, starting from polio, CP, to DDH, to coxavera, staphylocystic arthritis, Perthes, slip epiphysis. Every diagnosis which comes in mind could cause a positive Thomas test, right? So I know these over tests. You know things about over test. It tests the contracture of the iliotibial band or tensor fasciolata, right? So if you extend the hip and you hold the ankle, and if like in the lower picture, the knee fails to touch the opposite knee, or it fails to touch, it goes lower down, so there is a contracture of the ITV, right? Okay, muscles crossing both joints. So two joints. So muscles from both anteriorly and posteriorly, they cross the hip joint and the knee joint. So if you want to test that particular muscle, you want to relax it. So you should, if you want to test the posterior muscles, you should flex the hip. If you want to test the anterior, if you want to test the posterior muscles of the hip, you should flex the knee. If you want to test the anterior muscle of the hip, you should extend the knee, right? And knee extension is good in prone position, right? And if you want to check the iliopsoas, which is right coming about, you should do a Thomas, right? And you should, because it's come from the lumbar spine, right? So, so this is for example, this is a 12-year-old child, and this is the picture. Do you appreciate the picture? There is a slight scoliosis to the right side, and there is a pelvic tilt. So what do you do after this? How do you act? This is your examination finding. This is your finding in the examination. What do you do after this? What is the next step?
Looking at this child on inspection, we can see that there is a scoliotic curve in the spine to the right. The
Yes,
pelvis, the gluteal fold are not square; they are tilted towards the right side,
very
and
good.
I can see the feet are on the ground. There is no the feet are in equal. The left foot seems to be more externally rotated than the right one,
Mhm.
and
So what is your next
um,
step of examination? What do you do
to
after?
examine from the side and examine from the front. To inspect, to look from the side and look from the front. The next step is to ask the person to move so that I
Okay.
can observe the gait. And
Okay.
after that, I would like to examine the patient.
Okay. So if this is your finding, let me tell you, the next step is this. You put a block
Yes,
below the right foot, right?
yes,
If this deformity corrects, the pelvic tilt and the spine
it's
corrects,
flexible.
what does this mean?
This is a
What,
flexible deformity, and the deformity was because of the limb length discrepancy
very good,
on the
very
right
good.
side.
So this simple thing tells you a lot. So this deformity you have is because of limb length discrepancy. What if you put this block and the deformity did not correct? There is still a
Then
scoliosis and a pelvic tilt.
it's a fixed deformity, or probably uh, the deformity lies at some other level, either on the spine or the hip level.
Very good. So what is your next step of the examination now? This is the patient. This is
Next
the
step,
patient.
next
Yeah.
step is to ask the patient to ambulate so that we can see whether the deformity changes with the ambulation.
So the patient is standing on the block. Do you want to do anything before ambulation? I think you've
Um,
done ambulation before this as well.
okay. Um,
So, So in this
I think
position,
I
how
would
would you exclude spine contraction?
by flex in this position by flexing the person, asking the
Yeah,
person
you
to
would
flex.
ask the patient to bend forwards.
Flex. Yes.
So this is the next step is to ask the patient to bend forward. If the spine deformity corrects with bending forward, so spine deformity is again excluded. And the
Yes.
patient is standing on the block, so there is no limb displacement. So then there is it's a pelvic muscle contraction.
It's a pelvic muscle deformity.
Yes. But if the patient is asked to bend forward and the spine is not corrected, then it is because of
The fixed deformity in the
spinal
spine.
deformity. Right? Understand? So this is the next
Yes.
step. So now we come up to this thing. So this is very important. So on the left-hand side, this is a normal pelvis, a normal thing. So if there is any adduction contracture, so if the adductors are contracted, it would cause the shortening of this lower limb. And this shortening would not improve by putting the blocks below the foot. And it would not improve by bending forward as well. If there is an abductor contracture, it would cause lengthening of this lower limb. So by putting a block on the opposite side, it would not correct the pelvic tilt or the spine deformity. Because if there is an abduction contracture, so the patient uh, would like to tilt the pelvis to bring the lower limb into a straightened position. Do you understand this? Is it clear?
Can you explain this abduction contracture again?
Yes. This
The
abduction.
contralateral.
Yes. This abductor is shortened, right? So
Yes.
do you see my cursor? Do you see the cursor, right?
Yes, I can see. I can see.
Okay. So if this is shortened, so the limb would like to the femur would like to be in this position, right? In abducted position, and the pelvis would be then straight. If you
Um,
put the limb in abduction, right?
Yes.
So if there is an abduction contracture, you see my hands
Yes.
on this limb. So if the patient abducts the limb, right, the abductor would relax and the pelvis would be straight.
Mhm.
The patient adducts the foot. The abductors would not allow to adduct the foot, right? So it would tilt the pelvis with them in adduction. Understand? So this would cause lengthening of this particular lower limb, right? And shortening of the opposite limb. So this is how if you put the block, if there is a pelvic tilt and if you put a block on the shorter lower limb and it is corrected, so it's a limb length discrepancy. If it is not corrected, it's either the spine or the pelvic. If you make the patient bend forward, if the spine is corrected, then it was the spine. If you make the patient bend forward, the spine is corrected, and it's a pelvic tilt. And if it's an adductor tilt, then it would cause shortening. If it's an abductor tilt, it would cause relative lengthening. So then you would like to know the range of movement of the head joints, right? So you make the patient lie down and you would see the adduction, and you would know the pathology, right? Okay, so in prone position, the hip rotation is checked in flexion and extension as well, right? Understood? So in flexion, there are if there is an intra-articular pathology or intra-articular problem, it would come up. In extension, if there is a bony pathology, mostly it would come up. So well, how would you like to check the hip rotation and extension? You could check in supine position, but it's not accurate. In prone position, it is very accurate,
by
right?
flexing the hip, can't we check the internal and external rotation?
Yes, but you would like to check it in extension as well, right?
Okay.
you would like to check the rotation in a flexed hip and in an extension hip. Similarly, you would like to check the adduction and abduction in a flexed hip, especially the abduction, and in an extended hip as well. Because what happens when you flex the hip? If you flex the hip, the intra-articular becomes lax. The anterior muscles become lax, and the posterior muscles become tight if you flex the hip, right? But again, if you flex the hip and you flex the knee as well, the posterior muscles will also become relaxed. So you are purely checking the intra-articular pathology. Understood? And in extension of the hip, you are checking the extension of the hip, the anterior muscles are tight, and you are checking either anterior muscles or the bony deformities, right? Okay, should we proceed?
Yes, sir.
Okay, thank you. So these were the important things which I wanted to mention, because during exam our trainees get confused in these things. So now you have to present your case. So the presentation should be very logical. It should have a very good pattern. The aim should be to include initially all the differential diagnosis in your presentation, and slowly and gradually with each symptom you should exclude one or the other differential diagnosis, and you should come up with one or two differential diagnosis at the end of your history, and then your examination should prove and exclude the other differential diagnosis, right? So if you do this and you do a logical interpretation, logical presentation of history, then it becomes easy for us examiners to get you through into the exam. So examination, you would like, how would you like to present your examination? So what I would do, I would, on examination, the general look of the patient. It's a young patient, a young child, and a docile patient lying comfortably in a bed with a walking aid or with a brace applied, things like this. Is the general look of the patient. Then the GPE, you could quickly say that there's nothing on GPE or there's something. A systemic examination, and then you do a detailed local examination, presentation of the detailed local examination to the examiner, and then you give. So if the examiner is happy with your history and examination, he would directly ask you, so what is your diagnosis? So if this is the next question of the examiner, then you could be very confident that you have done well. But if if the examiner asks you questions in your history and in your examination, and see how have you done this and how have you done that, and have you done your Thomas or have you done your LinkedIn discrepancies, then you think that you are in some sort of a little trouble. But you should keep cool, still keep cool, and maybe you could overcome that. So any questions up to this point? This was a history and examination of the patient with a hip condition. Any question?
Usually we don't do these rotational profile in supine position. So I personally feel that now it's after a lecture, we should do it, and it's mandatory probably to do rotational profile prone position.
In lower limb pathologies, I think rotation profile is important. It takes only about 30 seconds. And if you are quick enough, you can do it, I think. Yeah. And it points to important findings.
So in our exams here in the UK,
yeah. Anything else?
We are asked to do Stahili profile.
Thomas, sorry, Dr. Mudawar is saying something.
So we are doing Stahili profile, which we make the patient walk, make a tiptoe, put straight line, see how far they are off the profile. Then we find out whether it's in the ankle, it's in the knee, or it's in the femur. So I think Salik Sahib is correct. The rotational profile of lower limb is absolutely vital, and we should know how to do it. It doesn't take more than a minute to do it anyway.
Sir, because my thinking is this, if the patient is having flexion contracture and we are making the patient prone, so wouldn't it be painful and cumbersome for the patient to lying in prone position, having the flexion contracture of say 30-40 degrees?
But you can say in the exam that the patient has got obvious pathology and contractures, so the reading of results I'm going to get is going to skew, do you actually want me to proceed? And if he says yes, you have to, and if he says no, you don't have to.
Yeah, yeah. this is the same thing as if the patient cannot walk, how can you check the gait, right? If the patient has a flexion contraction and cannot make him prone, then it's obviously, if you cannot, but if he can, you should just do. If the patient cannot walk, you cannot check his gait, but you should ask him to ambulate. How does he ambulate? Can he ambulate with his with his knees or things like that, right? So if it's possible, you should do it. Obviously, if there's a mild flexion contraction, 10 or 20 degrees, it is possible. But if it's more than 30 degrees, it's a little bit difficult. But there are ways to overcome that. But I think we don't need to discuss it over here.
Yeah, I mean,
there are ways to
How to
overcome
do,
that.
Thomas, in
we
Yeah.
are telling you everything. That doesn't mean you have to do everything. You see, if somebody comes in with a polio and you're trying to look at motor power, then that shows how you can't do what the book says you have to do and sort of modulate it and make it bespoke according to your needs. Salik Saab is giving you the general view of what you should be doing, but that doesn't mean you have to do all these tests in everybody that you see in your exam line.
Sir, one question, how to do Thomas in the patient having bilateral flexion contraction? Should we do in the
Yeah,
lateral,
it's
or
very
should we do supine?
it's very easy. I mean, if it's a flexion contraction, the patient can flex his hip up to normal, but he cannot extend it, right? So you flex both the hips, make the lumbar spine straight, put your hand behind the lumbar spine, and you ask him to extend one hip, right? And see the flexion contraction, for example, the right hip, and then you again flex both hips, and then you ask him to extend the left hip. You see the flexion contraction of the left hip.
Right, sir.
Okay. Right. Anything else? So now we will discuss a little bit about the abnormal gaits in hip pathologies, right? A little bit, just a little bit overview, because this is important. So I hope you know all about antalgic gait, right? It's a painful gait, and the patient, the stance phase is decreased in the affected limb. The time of the stance phase is decreased, right? Antalgic gait. This is all about antalgic gait. Trendelenburg's gait. Again, just like Trendelenburg sign, the patient walks with swaying to the, when there's a pathology, it sways towards that pathology, right? And if it's a bilateral Trendelenburg's gait, it sways, it's a waddling gait. He sways to right and left, right? Then there is this shortening or dipping gait. So shortening is less, the short leg is not the and up to 4 or 5 centimeters, the patient can compensate it by equinus, right? But if the patient wants to keep the heel on the ground and it's more than 5 centimeters, then the patient dips to one side while he's on the stance phase. So it's very important to differentiate this dipping gait from antalgic gait. In dipping gait, the patient dips towards that side, but the time interval of the stance phase to the opposite stance phase is the same. The time interval is normal, but he just dips. He doesn't sway. He dips towards the side which is short. So this is a shortening or a dipping gait. A circumduction gait. When the patient fails to clear his foot from the ground. Okay, for example, there's a common periodontal pathology, or there's something in the lower. The patient fails to clear the foot from the pathology, so he sways to the opposite side and he gives a circumduction motion to the hip, and it's a circumduction gait. If the hip flexion is normal, so this is uncommon, but if the hip flexion is weak, then this circumduction gait is very important. It's very common. So a gluteal lurch. So what is the function of gluteus maximus? It keeps the hip extended during the stance phase. So if the gluteus maximus cannot keep the hip extended in the stance phase, the patient would stoop forward during the stance phase of that limb. So preventing that stooping forward, the patient lurches his back. So this is a gluteal lurch. So whenever the patient puts weight on that affected limb, he lurches back, right? So to extend the hip and preventing himself from stooping forward. So this is called a gluteal lurch. So whenever there's gluteus maximus weakness, so there is a gluteal lurch. So how would a gait be when there is a flexion contracture of the hip? So there would be hyperlordosis in the spine phase, so his buttocks would become prominent, right? So whenever the patient is putting weight on the limb in which there is a flexion contracture, the lumbar spine would hyperextend and the buttock would become prominent. So this is hand on knee gait, this is for the knee, equinus gait, this is for the foot, steppage gait again for the foot, Sigurdsson gait is for CP, okay? Crouch gait is again for CP, in which the hip is flexed, the knee is flexed, the ankle is dorsiflexed as well, right? Okay, jump gait. Geno recurvatum, okay. So don't forget to examine the abdomen in male and females and testes in boys during examination. Okay, so we will discuss a few scenarios and then we could end this presentation. Right? Are we ready for that?
Yes, sir.
Yes.
Okay, so for example, it's a 10-year-old child, right? And there is a 2 centimeter shortening, right? And there's a 2 centimeter shortening, and the abduction is normal. The adduction is slightly increased. There is decreased internal rotation, right? And it's painful. And the flexion extension is normal. So what does come into mind? Or what are the conditions that come into mind? It's a painful thing. So obviously,
Acute escapee.
Is there? It could be a painful
Acute
hip
escapee.
pathology.
yeah.
Yes.
So there is some intra-articular
septic
pathology
arthritis.
going on, right? Intra-articular
Yeah.
pathology, there's pain on internal rotation, right? Internal rotation is limited.
Yes.
Can
So
I just advise you,
it
right?
could
Yeah,
be,
so it would be a septic arthritis, which is a compensatory flexion deformity of the hip.
okay, so in septic arthritis, all the range of movements would be extremely painful, not just one range.
Just a minute.
It's his disease.
Ask the question in the
Okay.
exam. You have to
Yeah.
ask questions back. You must say, how old is the patient? In a 50-year-old, this is different. In a 2-year-old, this is different. You
Yeah.
must know what the age of the patient is. Pathology is separate. Sufis is separate. Half the diagnosis in the age of the patient. You must
Yeah.
ask instead of answering the question. Otherwise, it does not show that you understand what you're talking about. You must say what age is the patient before you answer this question. Like when you see an X-ray, somebody shows you an X-ray, you must ask for the second view before you comment on it. These are all prerequisites of exams. You must ask the age of the patient.
Sir, as the sir
So
has said that age is 10 years, so probably this can be pathology, or if the child is chubby or fatty, so we can think of skippy as well.
yes, you can think of Sufi, but Sufi would not be the primary at 10 years. So this is some intra-articular pathology we are talking about. It could be a transient hemarthrosis, or it could be some, we haven't asked about the history of trauma. It could be a osteoarticular fracture or something intra-articular labral pathology or things like that. But pathologies and slip femoral epiphysis at 10 years you should consider, right?
We can label
Right.
it as a tuberculosis also.
Yes, you may. You can do that, but in tuberculosis, the shortening is quite later on. So if it's a
But also,
painful
again,
stage, then
common things first. How common is
yeah.
it tuberculosis of the hip do you see?
Yeah, it's
Very
common.
common.
Oh, I don't know.
Very common.
I've never seen one, so I'm not sure about Salik. I will tell you how much does he see, like you say.
In
In a
Pakistan,
10
it is
years
very
old,
common.
okay. In Pakistan, it's all common, but in a 10 years old child and hip in being involved, it's not that common. But you should put it into different sizes. No one would object to the TB hip, possible septic arthritis. Okay, so there's another scenario. It's a 5-year-old child, right? and there is a 3 centimeters shortening, right? 3 centimeter shortening, which is supratrochanteric, right? The adduction is increased, the abduction is decreased, especially on extension,
DDH.
right? Don't jump into conclusions. The rotation is normal, right? Flexion and extension is also normal. So what could be the diagnosis? I said
it could be a DDH.
it could be DDH, but I said the rotation is in DDH. The rotation is slightly increased in especially external rotation, and the abduction in extension is not decreased as much. I mean, the abduction is decreased in flexion and extension both at the same time. So what is the condition in which the abduction is improved while flexing the hip? And there's supracontrochanteric shortening. The rotation is normal. So it's not a slip. Obviously, it's a 5 years old.
Maybe coxa.
Very good. So this is a scenario of congenital coxa, right? So in extension, there is hinged abduction. So abduction is decreased in extension, but in flexion, it is almost normal. The rotation is normal. There is slight shortening, right? And the flexion extension is normal. So this is a scenario of congenital coxa. So this is how you think
Right.
while you are examining this patient, right? Any patient. Understood? So there's another scenario. So it's a 8 years old female child, and there is slight shortening, 0.5 centimeter shortening, and there is in decreased internal rotation. There is normal abduction and adduction, and the external rotation is normal. It's not increased, and flexion extension is also increased. But the internal rotation is not painful. It's a painless decrease in internal rotation. It's an 8 years old female. So this is your examination findings during your
Internal
exam.
rotation is can
Is
increase the
there is no internal
external
rotation on
then it's
flexion or extension.
Slipped capsular femoral epiphysis.
Or in an
Because
8-year-old child.
Uh,
In an 8-year-old child.
I could not get the whole picture.
There is intra-articular pathology, maybe pathology.
But it's not painful. Okay, it is pathology, but the painful stage of the pathology is over. It's a sequelae of pathology disease, or it's in the fragmentation stage or later on stages. Okay, so this is okay. So I have a few scenarios, but I think this concludes my lecture. I don't know whether I've done okay or not, but I have not discussed any particular pathology or disease, but I just wanted to give you overview of the hip pathology, how to approach the patient during your exam. If you have a certain examination finding or such a finding, and how do you react to it, and how do you interpret those findings. Hopefully later on we could do lectures on particular diseases. I mean, it's very difficult to put in all these diseases of hips into one lecture. I mean, there is, if I want to discuss Perthes, I could talk about Perthes for an hour, slip for an hour, DDH for an hour, or in maybe 2 hours. So I just wanted to give you overview about the hip pathology. So you are welcome to ask any questions. You can also, yeah, you can also send me emails. I can give you my email, or you can contact me on WhatsApp if you have any news later on.
So thank you very much. Just wait for other people to ask questions, but yeah, we cannot cover everything.
Sir, the thing which we are facing here with the senior examiners, that sometimes we do Trendelenburg just from the front. So sometimes they say, okay, you should be doing from the back by putting your thumbs on the nipple of nevus. Some examiners just say, okay, don't give a hand to the, or put a hand on the patient. Just ask him to stand on one leg, then ask him to stand on the other leg. Same is the condition with the rotations, that movements of the hip, that some examiners say, okay, to check the movements of one limb, just drop the other limb down the table so that the pelvis is fixed. Now check the movements easily. So what to do with this?
So this is a very, individual preferences. But I deliberately did not want to discuss. There are many ways you could skin a cat, right? You could do. I mean, if the pelvis is dropping, you can appreciate it from the anterior or posterior. You can appreciate it with your eyes. You can appreciate it with your thumbs. You can appreciate it while holding the patient. That doesn't matter to me. For some examiners, it would be important. You can ask for particular examination what he would prefer. But personally, if you can elicit the pelvic drop, or you can elicit the pelvis is now straightened after this, it's enough for me. I mean, there's many ways you could do many things. I'm personally okay with that.
So you must,
Mr. Munawar, if you want to comment on this.
whatever you're doing, you must look like you're confident and you know what you're doing.
Mr. Munawar, we cannot hear you. Your mic is muted open.
Or maybe it's okay. It's not mute.
Yeah.
It looks like it's. Well, can you hear me now? Yeah.
Yeah, it's okay now.
Yeah.
I can hear you.
So remember, in the exam, whatever you're doing, you must flow. If you are stopping, that is when the examiner intervenes. It doesn't matter to him whether you lock the hip or unlock the hip. That's what you're talking about. Drop the leg on the other side to check rotation. Yeah, whatever you do, in a child, it is totally different to an adult. You cannot do the adult examination method in a child. Half the time, the child will be crying. His mom would not allow you to get near him, or he would not come near to you. Just understand. You need to flow and show your examination. So before we stop, I want to ask a question. Actually, this is for the trainees now, the people doing exam. So if you have seen a 5-year-old child, okay, and the 5-year-old child has come in with a limping gait, you have examined him, there is nothing to localize. You've done an X-ray, X-ray does not show anything at all. You have done an MRI scan, the MRI scan is totally normal. So how are you going to make a diagnosis of this patient? What else can you do to confirm a diagnosis? You know, from 5-year-old age, it's either an inflammatory disorder, an infection, what do you call them, pathologies, or the patient has what we call, the transient synovitis, where they have a painful irritable hip. So what test can you do to give you a diagnosis here? Because this was asked from me in my exam when I was doing my FRCS orthopedic exams. So basically every test you've done is normal. All the examination shows is a painful hip to make a diagnosis. 5-year-old. So how can you confirm pathologies in a person where there are no signs on X-rays, MRI scans, etc.? Do you know how to age a person? Do you know how to age a child? If I ask you what is the chronological age of this child, how will you tell me?
The skeletal survey we can do.
What, sorry?
The skeletal survey we can do.
No, you do something called the Grulich Pile Atlas. You look at the person's hand and bone age of the hand. Yes?
Yes.
You've read that? So in Perthes disease, the chronological age and actual age do not match. See, if the hand age is showing 5 years, but the child is 4 years old or 6 years old, actually, then the person has Perthes disease. So that's why the aging of the child is important in this particular condition. This is just not what I was asked, and I was fortunate enough because I'd read it and somebody taught me, I knew about it, but that's why I'm telling you. To age a child, you look at the hand of the left side and you do an X-ray of it, and then you age the child. It's called the Grulich Pile Atlas, and then you take it from there. But anyway, go and ask your questions. We can stop because I'm going to go in 10 minutes somewhere. So if you can ask your questions quickly, then we can come to a conclusion. Nobody wants to ask a question? Okay, good. So I am going to Pakistan to the AutoCon. So we will have a small delay for a couple of weeks, and I'll come back and we'll teach you before the exam is. If that's okay, we'll say goodbye, and I'll put this video on the forum then. And thank you, Salik Sahab.
Thank you very much. It was an honor. Enjoyed a lot. Thank you very much.
Thank you so much, sir. Assalamu alaikum.
Right.